mentioned, I've worked less than full time through my career. And whenever I do talks about less than full time, I always like to lay out the different things that I've done. So in green, I've got some of the medical career points, and in blue, some of my international sporting career points, while in yellow, more of the sort of personal things. And when I lay it all out like that, it all looks very nice and subdivided. But actually, of course, life is a little bit more about things overlapping with each other. And there's never a time where I've felt like, oh, well, I've got lots of spare time in my hands. And as I'm sure all of you feel, that life tends to clash with work, which tends to clash with deadlines, which clashes with academia. And sometimes all these things feel that they're getting on top of you. But short-term stress is a little bit different to what we think of as burnout. And that's a phenomenon we recognise in sport as something that is commonly referred to as overtraining, but perhaps is more accurately referred to as the unexplained underperformance syndrome. And when we think of overtraining in sport, it's been quite neatly defined as a persistent and unexplained performance deficit despite adequate rest. And that's to differentiate it from the fact that athletes will often train at a very high volume to try and build capabilities in certain aspects, and over that time they will become fatigued. But it's thought that then when they rest, they actually return stronger or faster or with greater endurance as a result of that high volume block. But when overtraining comes and strikes, then the athletes, instead of being able to recover during those periods of rest, actually have a progressive decline in performance. And we think of that obviously in a context, maybe a foot athlete or a swimming athlete, where their times get slower. They're unable to perform to the same capabilities that they were before. So they're running 800 meters slower than they were before. But this is a problem across all sports. And in something such as hockey or any skill sport, basketball or football, then not only is there a diminished performance in terms of strength or endurance, but actually skill execution is diminished as well. And so we can see that in, I think we've all seen painful times when an athlete just has an absolute crisis, burnt out, loss of confidence, and suddenly all that grace and elegance that we associate with high performance sport is lost. And you see an athlete that's incapable of passing a simple ball from one place to the next and unable to kick a ball straight. And it's terrible to watch. And I think we all feel for the athlete. And the key is that it's multifactorial. There's been lots and lots of hypotheses about whether this is about muscle endurance, whether there's a loss of neural reserve, but the key is it's multifactorial. And I think that is similar to burnout that we recognise in doctors, which is of course multifactorial as well. Whatever causes burnout in either medicine or in healthcare at large, it's a problem that's on the increase. And the most recent survey conducted by the BMA recognised that almost half of doctors are recognising suffering from some sort of mental health problem, the most common of which is burnout. In the same way that in sport, burnout or overtraining, unexplained underperformance syndrome can be defined, in medicine that can also be defined, and 3 particular dimensions of burnout are recognised, and that is emotional exhaustion, depersonalisation, and a feeling of lack of attainment or progress. And all of those factors are recognised in doctors at one point or another. There are scales which can be used to measure it. There's different dimensions which can, be said to judge when a doctor is burnt out or not. But one thing that I want to move away from is something I've been guilty of before, which is actually trying to measure burnout and giving an idea of a criteria where you meet through by, attaining a number of points on a scale, you now qualify as being burnt out. And I'll come back to the reasons for that, but I don't think it's particularly helpful to measure burnout as a binary number on a scale, yes or no, you meet it or you don't. I think the key point is that all doctors will feel this at some point in time, but for some doctors, it is a feeling which doesn't go away despite adequate rest, and it's pervasive in all aspects of life and not just whilst they're at work. And why does burnout matter to us? Well, we know that burnt out doctors, it's not just a problem for the individual themselves. Burnout is a problem for patients because doctors who are burnt out tend to, as I can show you in the top right hand corner here, doctors who are burnt out tend to make more errors. And that's errors across all facets, not just, for example, cognition. So it's not just prescribing errors, but it's also skill execution errors and also judgment errors. So in the same way that an athlete in sport who is burnt out doesn't just have problems in endurance or strength, it's actually a pervasive problem through all aspects of performance. It's also an issue for workforce planning. So doctors who are burnt out tend to leave the profession either full-time or part-time. We can see that more of our junior doctors are now taking a break after foundation training. And in fact, in the 2016 data, which I've illustrated in a chart in the bottom left, you can see that actually taking a break from organised postgraduate medical education is the most common destination for F2 doctors now. Some of these, of course, will stay within the NHS working as locums, but many of them will either go abroad or be lost to medicine entirely. And there's also a widespread problem which affects not only patients, not only workforce planning, but organisations. Organisations such as the mid-staffs, but I think a problem which is probably repeated across the country in much smaller parts, but in similar points, in that doctors who are burnt out feel loss of control and they feel unable to raise concerns about performance. And all healthcare staff, of course, should be guardians of quality, but I think doctors are particularly cognizant of problems which are across various departments because we've got a good visibility across the interaction of specialties. Doctors understand when hospitals are failing, and burnt out doctors will not be able to raise concerns in the way that an organisation that is robust will have doctors who are able to report. So burnout is a problem for all doctors, not just those who are directly affected by it. It is, however, when we get to the very nub of it, also an enormous problem for the individual. And mental health crises, I think we're all cognizant of the fact that doctors are more prone to suicide than the general population. And these two charts I've got here are from a meta-analysis, which it makes for just incredibly grim and sad reading, that the suicide rate in both male and female physicians is significantly higher than the general population. So not only are burnt out doctors leaving the profession, having problems with being involved in patient safety events, but also, unfortunately, burnt out doctors are more likely to die than the general population. As I mentioned before, burnout is multifactorial, but it is certainly on the rise. And I wanted just to highlight a couple of points just to raise discussion as much as anything else about why I think, particularly in the last 12 to 24 months, we're seeing a crisis in burnout in our junior doctors. This is an article by Atul Gawande, and I would, if anyone would go and read, I think this is one of the most fascinating articles. It's a New York Times article actually about why doctors hate their computers. And it is discussing the fact that doctors are actually among the most technically literate people in the population, and yet almost every doctor will have been heard to utter in their working week, I hate this IT system, this computer, this interface that I have, which is coming between me and my patients. And there's actually been studies that show the more interaction that a doctor has with the computer, the more burnt out they are. And unfortunately, that burden falls highest on our junior doctors. We found that paper is inefficient and that digitising health records increases efficiency and in the long term can be shown to increase patient safety. But the inefficiency of paper has been replaced by the inefficiency of humans, and in particular junior doctors, having to spend hours recording things on IT, trying to interface with different systems which show x-rays and CT scans, the ordering of them, the blood tests are often scattered across many different systems, and it causes incredible frustration for them. This is another point where, again, I have to admit to being part of the problem. We're also using our computers to shift work into the personal time, and delivering education at 8 o'clock on a Wednesday night is admirable, but over the long term, we have to think, are we actually using technology to our benefit, or are we shifting more and more burdens of healthcare into our own personal time? I think nowhere is that more pertinent, particularly on our mobile phones, which we carry with us everywhere. And almost always, every specialty will have a WhatsApp group, emails on their phone, and we're now becoming so accessible that the bound between work and life is getting more and more blurred. Whether that is by choice or whether that's not, there is a crossover and a bleeding of work time into your personal time. And that is largely through technology, which is supposed to be working for our benefit. The second item that I wanted to just touch on in terms of causing burnout is the sheer monotony of workload. Over the last 12 to 24 months, there's been a crisis like no other, of course, and the patients who've been affected, of course, it's a tragedy. But for doctors, it's also been an incredibly difficult time. And for a group who are naturally academically curious, who are naturally looking for diversity and interest in their workload, COVID has been an enormous burden on them. And looking after patients who are in many ways very similar in their pathology gives a sense of depersonalization. And I think that is particularly actually for our nursing colleagues. So although I've primarily focused on what happens in doctors and burnout, we have to really think of our nursing colleagues with the monotony of workload that they've been exposed to over the last 12 months. Patients who are often prone, patients who don't have relatives close by, patients who have very similar needs and demands. It couples that sense of depersonalization, and the sheer monotony of workload contributes to the sense of burnout. And the last thing that I wanted to touch on that's been a particular problem during the coronavirus pandemic is trainees at the moment are just hitting a brick wall. And if we say that in part it's defining a sense of lack of accomplishment, well, trainees have had a real sense of lack of accomplishment because their progress is being blocked. And their progress is being blocked not only in the bigger sense, so for example, the core surgical training interviews, which have been a bit of a disaster, the MRCS exams, which have caused them a lot of stress, but actually there has been a real sense in very small ways that their accomplishments are being stunted. So we're not getting access to training lists in the same way. We're finding it difficult to move trainees through rotations, and so their usual sense of accomplishment is being blocked. And that again gives them a sense that no matter what they do and how well organised they are with their time, they're up against a system which is simply not listening to them and is not responding to their needs. And so again, where I've been part of the problem before is that there's this idea that, well, perhaps burnt out doctors simply have a deficit in resilience. And it's very tempting to try and measure it. And I have, I would hold up my hands and say I've published research which was about measuring resilience in individuals. But to bring it back to the sporting example, on screen, what I've got here is a quote from a very talented English national team rower who came through the age groups as one of the most talented in her age groups, who was clearly physiologically and psychologically amongst one of the very best. And unfortunately, rowing just became something which was miserable. And as you can read on screen, where she was sobbing in tears on the water and got out her boat and simply never rowed again because she just felt so overtrained and defeated by the system. And I would say in my personal experience, I've seen that in the sporting field as well. I've seen players who were amongst the most talented and amongst who I would have thought the most psychologically robust were simply defeated by the system and gave up at a young age and never ever came back to the sport. And what we have to say is that that is not an individual who is at fault or is lacking something. That is a system which has broken them, and we have to turn back to the system instead of thinking this is about individual behaviour. And perhaps instead of setting some of our junior doctors Sisyphean tasks which they will simply never be able to complete in a reasonable time, and then blaming them for lack of progression or blaming them for burnout, maybe we need to start thinking about a system which doesn't repeatedly batter people over the head. And people can't be taught to resist beatings. We need to think about stopping beating our trainees on a regular basis. And so as I get a bit older, and certainly as I think that I have a little bit more leverage within the NHS machine, what I think to is this term, which is organisational justice. And when we look at meta-analyses of what contributes to burnout, organisational justice is about factors which are embedded within healthcare organisations that prevent them becoming burnt out. The reason being that the levers which trigger burnout are recognised over and over to be endemic within certain hospitals and certain healthcare systems. And we can all recognise these. And of course, they make sense just inherently at face value: excessive workload, excessive admin, the conflict between trying to balance your work life with your home life. As I was saying, that bleeding between work life and home life, the lack of control, of course, that is going to, over the long time, contribute to a sense of burnout. And organisational justice, on the other hand, is associated with doctors who don't tend to feel those factors, who have a work life which is organised in such a way that actually there is resilience built into the system. And in very small ways, I think that the NHS can engender a sense of organisational justice, and it doesn't need to be enormous factors such as another renegotiation of a junior doctor contract. It needs to be some of the most minor things to make employees feel like they are valued, and that there is a system that is looking out for them, and they are not personally responsible for this enormous burden that they're carrying of their mental health. Simple things: lockers, hot food on a Sunday, hot food on a Saturday, hot food out of hours, somewhere that doctors can sit down that is pleasant and nice to spend time in. PPE that fits the population. We've recognised that women in general tend to fail their fit test more often than men do. All these things would be possible without an enormous investment. It is simply engendering within a system practices which are designed to promote good mental health. These things are not difficult, but I recognise that actually, even as someone who's becoming more senior in the NHS, they are difficult because they span different departments and things are out with the control of doctors directly. So what I want is to give some sense of some of the smaller things that I think are helpful in managing stress. So many of the problems that trainees are facing just now are at this most basic level of what they need. If you can't eat, drink, sleep when you're working, then aiming interventions at the very top of the pyramid, including, I admit, what I'm doing just now, giving an airy fairy talk at 8 o'clock on a Wednesday, then actually you're not meeting the most basic needs of trainees. And I think some of the most impactful things that we can do as senior doctors actually are the most simple. So for example, sending our SHOs home at 8 o'clock in the morning instead of making them wait until 10 o'clock. Checking in with our SHOs that they've had a bleep-free period, or even taking their bleep for them for an hour so that they can go for lunch. Some of these things are incredibly impactful and are so appreciated by our junior doctors. And I admit, again, I'm part of the problem. I don't do these things often enough, but I am becoming more cognizant of it. However, the chance to do an airy fairy talk at 8 o'clock on a Wednesday is not one that I will pass up easily to listen to my own voice. And so I do want to just maybe offer a few little tips that I have found useful in training. And I would divide them into things that I think are useful in the short term, the medium term, and in the longer term. And that's in part based on my experience again in sport, where you set out what we call a macro cycle. And a macro cycle is the period over which that you have a performance at the end. So for example, if you have the Olympics in 12 months, then your macro cycle will be a 12-month long with the Olympics at the end of your cycle. But you will still have performances in amongst that. So to take it back to, for example, a medical context, I'm on a 12-month fellowship at the moment, and at the end of those 12 months, I need to be surgically competent to be a consultant. So that's my end goal. But within that time, I also had to pass my exam, get my CCT, perform certain operations to a level of competence. And so those smaller stepping stones along the way would be what they call a mesocycle. So the stepping stones along the way to your final goal. And then at an even smaller level, then you week to week commitments. So the things that you're working on from week to week, and that might be a paper that I would like to publish. It might be an on-call weekend that I have. It might be a time that my partner's away from work that I will have to be responsible for childcare. So that's something that I've taken into my work life again, and that I try and build out a plan for 12 months, 6 months, 6 weeks, and then week to week. And that lets me target the time that I need to use particular strategies to try and manage stress. And at the smallest possible level, there's something called attentional switching. And now that I tell you about this, you will notice more and more athletes that do it. It basically is the absolute converse of multitasking. And multitasking, I think, is an idea which has now been firmly debunked. If you can't use a mobile phone and drive legally, then there's no reason that you should think that you can multitask and do anything else particularly effectively. The reason is that there's a term called residues of attention, which is basically to say that when you're doing one task and then try to switch to doing another one, a small part of your brain actually stays with the original task. And the more often that you try and switch to different tasks, the more of your cognitive capacity is left with the previous one. So your brain continues trying to work through the problem that you've just left, even though you've just tried to move on to the new one. And so in sport, that could be, for example, somebody who has just mishit a serve, or somebody who has missed a penalty kick or something, and then wants to move on to the next task. But a little part of their brain continues to worry through. And what you will often see athletes doing is a little repetitive motion, which is most often an external cue that they use to try and trigger themselves back into the moment. And probably the most famous example of that would be Richie McCaw, who's an All Black, who's incredibly successful, who used to stamp his feet 2 or 3 times to quite literally ground himself and bring himself back to the moment. You would sometimes see the All Blacks deliberately putting out a call to all look at the stadium clock to understand what time of the game it is and what game situation should that trigger in their minds. In the Australian Open final last week, Naomi Osaka was repeatedly slapping her leg every time she went to return serve. And I just wonder if that was maybe one of these little attentional switching strategies. And I think that's something which is very useful in medicine, to be able to have a moment where you consciously park whatever you have just done and move into the next task. We have some of these moments built into our working lives already. For example, is there something that you could do? 3 deep centering breaths, stand with a particular posture, some sort of ritual that you find that brings you into the moment and allows you to perform that skill. However, it's never more important than finding something that you can do to switch your attention to home life. So when you get home, I would encourage all of you to do simple things. Turn off your smartwatch that tells you when you've got incoming messages and calls, and to do something that says, I have left work behind and now is my rest time. Mind that is in this moment and is leaving the day behind. In medium term, week to week, I always try to make sure that I do have at least a 6 week to 3 month plan ahead of me. And in that time, I will make sure that I know what are going to be the key points. And so I will start off by blocking days out. For example, the days that I'm on call. I block out those days because when I'm on call, it's very difficult to really plan. You'd be absolutely run off your feet. So that is not a time to allocate to anything else. But it's also equally important to be Abler, which is unshakable in your timetable. No matter what happens, you will say, I'm sorry, I can't deliver any project. The short of it would be that delivering projects over a concentrated period, number one, avoid monotony of workload where you feel like you've got 8 projects on the go, none of them are really making progress. You've just got every night that you're trying to tap something out without really getting to it. Instead of doing that, as much as possible, I try and concentrate work into short, high intensity bursts with a fixed end date. I simply must have this paper finished by a week on Tuesday, for example, because not only do you have the momentum that you gain from going back to a project little and often through a day, but you also have the sense of achievement. And that is a good counterbalance to the monotony of workload. When you feel like you've done something high intensity, high volume, but for a short period, you have the accomplishment, and then you've booked in a period of rest for once you've finished. And that's quite a nice way just to organise yourself to make sure that projects don't drag on and on. You get the sense of achievement. And instead of having 8 things on the go, you only do 1, but you make sure that you deliver on it. And that is a good antidote. The converse of that is that sometimes you have to manage the projects that you take on. And I would very much commend to you the idea that there are 2 answers to when someone asks, do you want to do a project? And the best answer obviously is yes, I'd love to do it for you. But the second best answer is a brief no. So think about it for a time and then come back to them with an answer of, I'm sorry, I can't take it on just now. Because it's far better as a trainee to let someone else step in and do a project well than have a consultant who's nagging you for a project that you know in your heart of hearts that you're never going to get back to. And also, I think if you can build up that trust with maybe just 1 or 2 consultants who you've worked for and delivered projects, you also get a sense of being able to trust them because they will give you projects which are simple and achievable for a trainee. And they have to recognise that actually sometimes very big but nebulous projects are not the best things for junior doctors to take on. Smaller, tightly defined projects which lead to papers and audits are just simply much more appropriate for junior doctors and much more deliverable in the timescale that we tend to have available to us. So it's a two-way thing. Number one, you need to build up your reputation of someone that delivers. And for me, that tends to be best done over short, high-intensity bursts. But also, you start to trust the consultants or the mentors you have for giving you projects that are appropriate. And the last thing that I just wanted to touch on is one of the longer term things is the idea that we're always told to work on your weaknesses. But actually, one of the most important things that you can do to build your self-esteem and self-efficacy is actually to build on the things that you're already really good at. And of course, there needs to be a sense that you meet the minimum standard able to do something. So the example that I would use in ENT surgery would be that we have to be emergency safe. So yes, rhinology might be my chosen subspecialty, but I have to be emergency safe. And so in this little bar chart that I've got, the grey example I've got would be, for example, otology. So I'm not as good at otology operating, outpatients, academic and management. And I need to be able to reach that black line of the minimum level of competence by the time I reach CCT. But once I've met that minimum level of competence, does it actually improve my self-esteem, my self-efficacy and my safety as a doctor to continue to work on those weaknesses? Or actually, should I think about improving the things that I'm already very good at? And in sport, that's sometimes referred to as working on what is your super strength. So if you're already very fast for example, and you meet the minimum level of endurance for your sport, why should you pour time into becoming middle of the pack endurance? Why not work on becoming the fastest athlete in your sport in the world? Because working on something which you're already very good at, number one, tends to play into the things that you enjoy. Number two, it will play into a sense of achievement because you're operating at an extremely high level. And number three, the chances are that you could become one of the very best in your field at what you do because you're interested, you've clearly got an ability for it. So why not pour your energies into something that you're already extremely good at? And that means that you need to take on projects which work towards building on your strengths rather than feeling that everybody needs to be an all-rounder. Just to finish up on it, I wanted just to then touch on some of the skills in time management. And I don't want to lecture on time management in particularly because doctors in general tend to be extremely good at it. And time management is one of those things that tends to come at the very top of the pyramid of actually, you know, doctors don't need lectures in time management, they just need a bit more time and a bit more pay. But some of the things that I've found to be really important in terms of time management is, again, breaking it down into that big cycle over 12 months. What am I going to achieve? What are the things along the way that I need to get there? And in the short term, and being able to have that insight into your 12-month cycle, being able to break down each moment and understanding how can I be at my most present in each of those moments in the short term, the medium term, and the long term will be something which I've found has been helpful in terms of managing my stress during training. I don't want to be blasé about it. I understand that there are many, many dimensions to stress and burnout, which I've not been able to touch on this evening. And many of those things are endemic within our organisations. But what I'd like to do just now is just open up to the floor to have some discussion about some other strategies maybe that you guys have used, some of the problems and the barriers that you've come up against, and maybe if you feel that any of the things that I've mentioned just now would be applicable to you.
So certainly for me, I would say saying no to projects is one of the best things you can learn, and the quicker you learn that, the better your life begins, or better your life is. I've certainly found that your seniors will respect you a lot more if you just say no, I can't do that at the moment, than to have a project that's unfinished when you leave. And also, as you get more senior, you get better at working out what's appropriate. So sometimes you can be doing somebody's ego project, and those are inevitably massive and never finishable. And so actually you get better at being able to say, actually, this project is possible in the 3 months or 6 months, and so I will take that one up, or I won't. So that was, I definitely agree with you with that. So Hannah Factum, if you would like to.
Hi, can you hear me well?
Yes, we can. Thank you.
Thank you for the talk. It was honestly very honest and heartfelt. What I found very helpful in reducing stress is that remembering whatever it is that I'm stressing about is not the end of the world. So what if I don't make it into this particular exam or that particular deadline? I mean, just remembering that whatever happens, I will be fine at the end of the day, and it's not the end of the world. And for me, this is something that gave me a sense of, so what if this happens? The worst case scenario, I get delayed 1 more year. So I guess that's something that I found very helpful personally.
Yeah, and I think that sense of perspective, it's just essentially medicine. And I think we all forget sometimes that we're actually an incredibly small cog in a really big machine. So outcomes, patient outcomes, academic outcomes are dependent on so many factors. I think the problem that sometimes we have is that junior doctors in particular are moved away from their social supports very easily. So they tend to get moved across the country once for university and then moved again for a job, and then they get moved every 4 months. And so they tend not to have great links either with their peers, and sometimes not with their family immediately close by either. And so they don't always have easy access to other people to put things into perspective. And it's quite easy to then catastrophize. And I actually think that, you know, part of anxiety and depression is to catastrophize, and it's incredibly difficult to get out of that mindset once you've got into it. And I think that's when I talk about organizational justice, or, you know, systematic resilience, in that we need to have better links for junior doctors to have people to talk to, and not just mentors, but sponsors, people that actually do things for them. So not just talking, but people that can actually do things to help them progress. So yeah, I think that in an ideal world, that perspective is so important, and I think that's a really good thing to rely on. But we need to find some way of being able to break people out of a catastrophizing mindset as well.
And I think when your only support system is the other junior doctors, that can be great for sort of going through a traumatic experience and debriefing from that. But can really, if everybody's catastrophizing about the same exam or the same papers that they need to get published, it can just sort of snowball.
Yeah, and I think sometimes junior doctors, you know, it's a bit like used car salesmen. People talk about how much they're doing, and you can't help but compare yourself to other people, and sometimes that's incredibly intimidating. And you know, it's such a basic thing, but one of the most important times in my career was finding out which consultants had failed their exams.
Yes.
You feel so much better because you realise, you know, just as you said, it's not the end of the world. Of course it's not, but you need concrete examples to understand it's not the end of the world.
Yeah, I agree. I remember so I failed my part 1 of the MRCS, and I said it in a training day, and with the core surgeons, and all the core surgeons were at my level were like, oh my goodness. And then afterwards, 4 individually came up to me on my walk home and said, by the way, I failed too. But nobody had the guts to say it in the room. And yeah, and I'd been completely shot down by the consultant who was leading the session about how I couldn't be a surgeon, etc. And then 4 others said it on the way home, and that made me feel like bad that nobody else could say it in the room, and I'd taken the brunt, but really glad that other people had failed as well.
Yeah.
So,
Yeah. And I think sometimes that social media really doesn't help with that as well. I know we blame a lot of things on social media, but I think there is a sense that everybody is flying when you look at social media. And often when somebody does put their head above the parapet, it's quite easy for people to jump on, you know, this big pylon in social media. Well, in my day, we used to work 120 hours and polish the consultant's boots as well. It's not helpful. It's not a supportive environment, but that is more and more what, you know, young people, but yeah, the younger generation do look for support. And I think sometimes as senior doctors, we don't always appreciate the impact on people's mental health that has.